think Ladha madam is in the wait room, I think.
Someone has to.
We can start, sir.
Start, sir.
Yeah, I think we'll start.
Joseph, sir.
Yeah.
You can welcome address.
Yeah, sure. I'll just start with that. So, respected our faculty, Dr.MONI sir, our own member. Dear senior members, colleagues, and friends, a warm good evening to one and all. Getting stuck with this third wave of pandemic, we are forced to forbid from our physical activities as such right now. And still, we want to go ahead with a couple of our programs for our academic as well as practical point of view for our practitioners as well as our students. So we are continuing with a couple of programs. And today we have an eminent speaker with us who will really enlighten the day, the World Cancer Day, with his knowledge and experience and the importance of the World Cancer Day as well as regarding the fellowship program and how to go ahead with it if one is really interested in especially addressing on our PGs as well as young budding surgeons who have already into the field who have just started their practice. I hope this program will enlighten them or will be an eye-opener as well as give them the information what they require in order to choose their career in oncology. We are also coming up with a couple of programs, going to have a trial run with a couple of programs like addressing on particular topics with as case discussions or a panel discussions for specific topics such as orthodontic implants and all this thing, which we will have a trial run. By next week, we'll start with an orthodontic program. So I hope with these programs, we'll make ourselves active and get involved with academic programs as well as for the practitioner level as well as from the the academic view of the PGs. I wish and invite all success as well as invite all of you to be a part of this program and hope that this will be an eye-opener as well as be informative for the youngsters who are in the field. Thank you.
Thank you, sir. Very good evening to one and all. To moderate our session, we have dynamic and versatile head and neck onco surgeon, Dr. Sudhish Manoharan. Dr. Sudhish did his MDS oral and maxillofacial surgery from Government Dental College, Kottayam. He later on went on to do fellowship in head and neck surgery from Malabar Cancer Center, Talasheri. He is fellow of International Board of Specialists in Oral and Maxillofacial Surgery, as well as member of Royal College of Surgeons, Edinburgh. He has several oncology-related publications in reputed journals and has actively discoursed on various aspects of head and neck oncology. He is presently working as consultant in Department of Surgical Oncology, MBR Cancer Center and Research Institute, Calicut. Over to you, Dr. Sudhish, to give an outline of today's program, as well as introduce the speaker of today's session, Dr. MONI KURIAKOSE. Thank you.
Thank you, Varun, for your kind words. A warm greetings from AMSA Kerala. Let me share my screen to put a few words on Moni sir. Is my screen visible? Varun, is my screen visible?
No, Sudhish.
Yes, sir. Just a minute.
Not yet, not yet.
No.
Still not visible, right?
No.
Sorry, sorry for the glitch. Okay, I'm not able to share. Okay, I have made a presentation on what is that. Okay, closing the care gap is this year's World Cancer Day campaign, and every one of us has a role to play to make cancer care accessible to everyone in the world in equity. And to spread the message, we have the most apt person today as our faculty, and it is none other than Dr. MONI Abraham KURIAKOSE, who is the medical director and CEO of Kerala Operations Cartnos Health, and vice chairman of Department of Health, Head and Neck Plastic Surgery, Roswell Park Comprehensive Cancer Center, New York. And when I contacted Moni sir, he was very particular that you should not make any formal introduction. But I insist that since today's majority of today's audience is trainees and budding maxillary surgeon, and I would like to introduce you formally to inspire them and to boost their energy towards aspiring their career in head and neck surgery. So Moni sir, he completed his BDS from Manipal University in 1983. That was when most of my generation are born. And following BDS, he went on to pursue his medical training from the University of Bristol, UK in 1992. And he completed his residency program in general surgery as well as in maxillary surgery from University of Bristol and Newcastle from UK. And he finished his fellowships from Roswell Park Cancer Institute as well. And he is an American board certified oral and maxillofacial surgeon as well. And positions held, there is a huge list of positions. I'm not going into all of that. Basically, he started his professional career as a dentist in India. Following his training in surgery and medicine, he went on to serve as an attending head and neck surgeon and director of translational research program in New York University in 1999. Followed by he joined Amrita Institute of Medical Science as the professor and chairman of the Head and Neck Institute in 2003. And he was instrumental in growing that department as one of the renowned institute in India, maybe worldwide. And he started the MCS training program as well in head and neck. And you know where Amrita Institute is standing now. And the stone was laid by Moni sir way back in 2003. And he left Amrita in 2009 and joined Narayana Hridayalaya and Masumdar Show Cancer Center. And he did the same thing, what he did in Amrita in Narayana as well. And Narayana Hridayalaya is also now one of the leading institutes of surgical oncology. And he was the founder director of Cochin Cancer Center and Cancer Center Kochi. And that institute is now in its initial stage. And from the history, we know where that institute is going to be in future, because the stone is already laid by Moni sir. And currently, he's the medical director and CEO of Kerala Operations in Cartnos Health. and Vice Chairman of Department of Head and Neck Plastic and Reconstructive Surgery, Roswell Park Cancer Center, New York. And he had more than 300 publications in various indexed and indexed in national and international journals, with more than 4,500 citations. That is a huge number and very admirable. And he has authored a 4-volume textbook on oral cancer, which is called the Contemporary Oral Oncology. It is one of the very comprehensive textbook which all the people aspiring oncology should read. And he's editor-in-chief of Oral Cancer, the journal Oral Cancer by Springer Nature Group. And apart from all these achievements, there is one secret which Monisa shared, that he failed in gynecology exam during his medical training in the University of Bristol in 1992 probably. And usually that is a straightforward losing 1 year, but he didn't leave it there. He was so determined that he don't want to leave that single year in his professional career. So he cleared all subjects of the medical course and in an LMSSA and exams in University of London in one go, and he saved that year. And it is not just that year that he saved. That is a determination that he showed to save that single year. And that is the determination that all of us who are aspiring as a surgeon and who admire Monisa should learn. Not these achievements as achievement list. This single thing proves what he is and why he is where he is now. And Monisa is on a mission to create a cancer center, cancer centers without walls. And obviously that is the theme of today, that is closing the care gap. And we have Monisa today to enlighten us with his thoughts to close the gaps. And being maxillofacial surgeon, we have definitely a role to fill up these gaps, and we can learn from Monisa. Monisa, over to you.
Thank you, Sudesh. Really grateful for your kind words, and let me thank Dr. Joseph and Dr. Varun for the kind invitation. You don't have to invite me because I'm part of you. I'm a member of AOMSI Kerala, and glad to be part of this discussion. Now, I'm delighted that AOMSI is celebrating the World Cancer Day. As Dr. Sudesh mentioned, the theme of this year's World Cancer Day is Close the Care Gap. So what I hope to do during the next 35 minutes or so is to discuss the role of oral and maxillofacial surgeons in closing that care gap. So in addition to that, Dr. Joseph, Dr. Akhilesh, and Sudesh has asked, send me an email listing what I should talk in this presentation. And they have about 8 points they asked me to cover, specifically addressing the next generation of oral and maxillofacial surgeons who are showing interest in oncology. So if I group that 8 questions, this comes under the 3 buckets. One is the training in a broader context. Then after training, how to practice. And there was a question about how do we do research in the field. So what I hope to do, as I mentioned, first I'll speak about the theme, this year's theme, that is the closing the care gap and what our specialty can do. And the 3 points which I was asked to cover, I will go into details of that. And I will not stop at that point. I want to do some exercise. I want you to, just by giving a talk doesn't mean much, is that right? We have to take that talk into actions. So I'll just list some actions which we can take it up for the future. Now, closing the care gap is the theme, and these are the images I've taken from the UICC website. And this illustrates that there is a gap existing, whether you're black, white, east, south, north, west, illiterate, literate, whatever, there is a gap when it comes to cancer care. And this is happened despite our increased understanding about cancer. So now, after the completion of the Cancer Genome Atlas, we know that at genomic level, what the cancer does. And we have a number of early diagnostic tools, personalized medicines with a lot of targets are there. When it comes to rehabilitation, multiple options are there, and psychosocial support to get them back to the normality. But if you look at that, there is significant barrier at every turn when the patients when they're seeking treatment. This can be rich, poor, literate, illiterate, but all that comes from few factors. One is awareness, lack of awareness of the disease, not just by the doctors or the medical community, but by the general public too. And there's a significant stigma and cost implication and everything. And there's a significant discrepancy between where you live, and also age also matters. And when it comes to that equity gap, UICC has used two terminology for us to understand. There is one thing called inequity, and second is called inequality. When you talk about inequity, means there's an unjust gap. That is avoidable gap. I'll give some examples of that. Second is inequality, means there is the resources are available, but unfortunately, for whatever reasons, is unevenly distributed, causing inequality. And giving some example again from UICC, the inequity gap. There are about 10 million population in the country, in the world with cancer. When it comes to India, it's about 1.9 million. But unfortunately, 70% of the cancer death happen in countries like India. And these countries, like low and middle income country, only about 30% of the population are accessible to comprehensive cancer care. Compared to that, to 90%, this is not a just word when it comes to cancer. Inequality, there is a lot of, even though a country like US with similar resources, there are racial differences. When it comes to cervical cancer, they have given some example. A white woman, the survival rate is 71%, black is about 58%. New Zealand, the local people have got twice common reason why they die, and so on. So there is inequality there. So I wanted to move from that, the global inequality or inequity gap, and then talk about focused on head and neck cancer we are dealing with. And then we'll come to this problem in India. And then finally, I will touch upon in our clinical practice, do we see inequality or not? I will give some case examples. So this is a paper looking at the prediction of mortality from head and neck cancer from 2016 to 2030. And they have shown that during that study period, they expect an increase in mortality by about 40%. But if you look at the global picture, doesn't happen uniformly throughout the country. There are parts of the world where the outcome is much better. Okay, and then they went and looked at why that should happen. And what they did was they used a ratio called the mortality incidence ratio, where the denominator is incidence. And they used one of the surrogate marker of performance of the health system. That is number of surgeons. When it comes to head and neck cancer, surgery plays a significant role. Whether the number of surgeons predicted the mortality or not, yes, it did. With increasing in number of the surgeons, the outcome, the mortality rate came down. And the threshold was about 20 per 100,000 population. That was the recommended surgeon population ratio by WHO. But increasing the number beyond that did not increase the outcome. From this, one can understand that the difference in the outcome is not because of some genetic predilection or something like it. It's just because of the poor performance of the health system. Now, coming from the global perspective to India, if you look at the incidence change, this is just every cancer. This is a paper published in Lancet Oncology in 2018. From between that, the study period, I believe 1990 to 2016, the incidence increased by about 28% throughout the country, if you take average. But states like Kerala and Mizoram, it's almost doubled. So within the country itself, there is a significant disparity. Now, I wanted to take you to one of your own clinic. And I'm going to give two patients example and see, just to put that, drive that, the message home. Want to tell you about this patient I managed sometime in 2009 or 10 when I moved there. So this is a time when we developed a technique of resecting masticatory tumors of the buccal mucosa going to masticatory space. And we showed that this can make a big difference. So this patient came from Bellary, northern part of Karnataka, and came and saw us. So I was so excited to see this patient, young lady, otherwise fit and healthy, with this tumor. I looked at the scan. For me, whether it's resectable or not, it has not gone through the inferior orbital fissure, has not gone inside the brain. So I said, yes, we can remove. We know from our data, we have about 60% chance of cure. That is better than zero. That's the time I asked the patient, do you have any questions? They don't have no question. They just went out through the door. And she came with her husband, must be very young looking person, and a father, it looks like somebody like a father. And when she was about to leave the room, she just turned back to me and asked the question, how much it cost. Okay. She did not ask me whether she's going to have disfigured, she's going to eat, drink, even whether she's going to be alive. The only question she asked was how much it's going to cost. Unfortunately, we could not save Sarojini. She failed from the local region disease. Okay. And if you ask the story about Sarojini, it actually goes back almost 2 years before I had a chance to see her. She was a stone cutter by profession. She used to chew gutka. Then she had an ulcer in the cheek, went to a dentist, thought it may be because of some bad tooth. Tooth was removed, then went to the medical college. After about almost a year, it was diagnosed as a cancer. The treatment available in Bellary was radiotherapy, gave radiation, then did not work, gave chemotherapy, and then came back to me. Okay. If you ask me why she died, because of the system failed. Okay. Now, second patient is a patient I saw about a month ago. It's a young IT profession from Bangalore, but living in Palakkad. Came and saw me with this ulcer. I know almost all of you just by looking, you know what it is. Okay. Not because I'm talking to you as a cancer doctor, you know, but just looking it has all the look of a cancer. Just 1 second, you know what it is. But this patient had seen a dentist about a year ago with a erythroplakia, and then they did a biopsy or some kind of white patch or something, and there was no cancer or dysplasia, so ignored. Then 6 months back, patient came and saw one of my colleagues at the hospital where I operated, and then said that maybe because of tooth bite, then patient was sent to a dentist. Then patient went back, did not do anything. This is how when she presented to me, there is a significant lesion going inside the tongue, reaching close to the midline. So I had to do a near total glossectomy to remove the tumor. Now, if you ask the question why that, by the way, this patient doesn't have no risk of habit of smoking, chewing, and other things. If you ask the question why it failed because system failed. Because if you ask the two patients, whether you're rich, poor, whether you have access to healthcare, the reason why we are losing patients because system failed. System failed because the complexity involved in the care. If you just put yourself in either of these patients, none of them wants to get diagnosed with cancer. Not even doctors just want to give that bad diagnosis because of the significant stigma attached to it. Nobody owns a cancer, not just oral cavity cancer, any cancer. Primary care is almost like it's detached from the rest of cancer care. They are not integrated with cancer care. This, we believe, is one of the fundamental reasons why we are losing the battle against the cancer. The road the patient have to take, either the serogeny or the last patient I spoke, it's fairly convoluted, and patient get lost, and then we lose patients. Now, put that aside, think about how you can address in your practice. Okay. Now let's go to that the other three topics which I was asked to cover. That is training, practice, and research. When it comes to training to train a maxillofacial surgeons to become a oncologic surgeon, we can equate or we can compare that to developing an engineering product from a raw material to spare parts to prototype to final product. And that training happens when you convert that spare part into a prototype. And the training do not make you a final product. The training is from your knowledge to provide a service, a prototype, which you can refine to become a better, a comprehensive surgeon. Now, what should be that final product should look like? So that is the way we need to reverse engineer. Then only we can design the appropriate training program. If you look at what should be that final product as a maxillofacial oncological surgeon, these are some of the attributes that we should have. That person should lead an oncology team and should lead a tumor board and should be a cancer doctor more than a surgeon. If you try to become a technician, he or she will not be able to perform well as a maxillofacial oncological surgeon. Of course, we should have the technical proficiency in surgery. That is taken for granted. I want to point out that getting technical competency is an easier thing to do. If you do neck dissection for X number of time, whether you have talent or not, you should be able to become a safe surgeon. Whether you go and become the best surgeon in that field, it may not be, but definitely you can become a safe surgeon. Definitely, you should have the skill set for reconstruction, rehabilitation, and supportive care. And then finally, I just want to point out that we should, as a maxillofacial oncology surgeon, should add value addition to the patient and should be acceptable to the health system because we are going to be part of that system. And finally, the point I was asked to cover, the last point, that is about research. We should, if you're passionate about that field, we should push the boundaries of the field. You will try to contribute to the knowledge rather than just becoming a sponge and acquire knowledge. Now, then if that is the skill set you need to become a maxillofacial oncological surgeon, the question is what other training opportunities you have in the country. There are two broad groups of training programs there. One is a university accredited fellowship program. One of the first university accredited program was started in Bangalore by RGUHS. We started that when we were at Narayana Hridralaya, along with the Kidwai Memorial Hospital, and now there are multiple centers out there offering a 2-year training program. Then there are a number of institutional fellowship programs. MCC, I'm just giving some examples of that. Multiple programs are there. I just want to congratulate our association, AOMSI, showing interest and starting this fellowship centers. I believe there are about 12 centers are there throughout the country. And what is important about this fellowship is fairly structured training program. Whether you are getting trained one place or another, you get fairly standardized training. Now, one sad part is that unfortunately, we do not have a DCI or National Board accredited training program. Unless we have an accredited training program, whether you get training or not, you will not be able to use that training to get a job or get yourself enrolled in one of the insurance programs, whether run by state or by private insurance program. So you will get training, but unfortunately, you may not be able to get the appropriate placement. Now, the other question I was asked to cover was a training opportunity abroad. I am quite, experienced to do that, to state that. I want to say that there are multiple training programs all around the globe, but considering the number of patients we have in the country, I strongly believe that India can offer much better training program than anywhere else. But just to give an outline of a training program, opportunities and programs in the other part of the country, this is where I did my training. After your undergraduate BDS, you go through a MBBS program. Now there are contents MBBS lasting for about 2 years. Then there are CCSTs, and then there are for about 6 years. Then the 2-year head and neck fellowship that is open for plastic, ENT, and maxillofacial. All together, you take about 16 years after completing your +2 to get that training. China has a DMD program where you combine your the pre-medical, preclinical years together, like a medical student, medical and the dentistry. Then you focus in OMF. Then there are about that takes about 6 to 8 years. But unfortunately, after that, the training program is it's not a structured one. You undergo something called apprenticeship that lasts for several years. Again, altogether, it takes about 16 years. Japan is almost exactly like China, whether you have a medical training. They don't have formal medical training in either places, but their dentistry and medicine. Dentistry is almost like a super specialty over undergraduate medicine, except for the last 1 or 2 years, they have a similar training program. US has got one of the most structured training program, DDS and MD. MD is integrated with that maxillofacial training program. And there is a fellowship program lasting to 1 to 2 years. Altogether takes about 9 years. But mind you, they have spent about 4 years in undergraduate degree course before they can get into this program. IAOMS started a global training program. AO fellowship programs are there. IAO with AOCMF is about to launch that. I'm the president of that organization. We're going to start a fellowship this summer. Then US is a good example where they started a CAQ, certificate of added qualification, on top of the fellowship. This became a nationally approved or legal training program. Unfortunately, our country, this is lacking, which I request our leadership to take note of that. Now, once you get a training, how do we practice? Okay. This, I believe, is where we have job problem. I have trained a number of, our group has trained a number of maxillofacial people. I can be very proud to say that they have come out as some of the best trainees we have ever trained from any disciplines. But unfortunately, if you look at their placement after training, is really it's a sad fact. The reason I believe is that these are the list I mentioned about this final product of Maxillofacial. The two reasons I believe is because where we ask the question whether our training program add value to the patient or not. Second, whether this is acceptable to the hospital system. Let's take these 2 points. Okay. If you go to that Sarojini patient I mentioned, she doesn't care whether it's treated by a maxillofacial trained oncologist or a surgical oncologist, whatever. She asked the question whether my doctors have played a role in early detection, whether my treatment helped me to survive better, and whether I could bring the cost down, and so on. And finally, she will be concerned about disfigurement and dependency on others, whether she convey that or not. Now, imagine if there was a maxillofacial trained oncologist was there in Bellary. By the way, now we have one of my students is there. But most of our trainees, when they complete, they try to stay in big cities. They don't want to dwell or go into smaller cities where they actually need it. And they try to stay within the comfort of big cities. That I believe we should discourage. We should be brave to go to the community, and that is where we are required. Now, when it comes to the hospital system, just find out what they expect from a maxillofacial oncologist. First of all, they ask the question whether he or she is able to manage the patient. With your training, we can, of course, convince them. And what value addition to the existing doctors, surgeons, that we have to ask. And of course, the cost implications, and ask the question whether they will attract new patients. This is where we have an edge over most of specialty, provided we work with the dental community and work with them for early detection and develop a network. Then we should be able to attract more patients. Finally, about the research part, the research, when it comes to research, I've had the opportunity to train or involved in or guiding multiple students, as well as reviewed multiple theses and everything. One of the problem I see is that we try to waste our time doing Me Too research, just copy some research done somewhere else and say that not being done in Indian population, so I'm going to do it. That is totally brainless type of activity. If you have some kind of inquisitiveness, there are lots of problems, clinical problems we can see in our daily practice where it is begging for answers. This year's Padma Award awardee, one of the awardees from Nagpur area, he was working in a small rural area, published several Lancet paper based on his experience from snake bites, and then just because of the meticulously documenting and asking the right question, could do groundbreaking research. So we have to do research which are there to address the clinical problems. In my case, I was working in multiple areas, from pure science to significant translation research, but later the half I focused mostly on early detection and how to integrate health system, how to integrate cancer care with the primary health care and so on. When I was director of Cochin Cancer Center, we did an experiment like that. We asked a question whether we can integrate the primary health with the cancer care. I will not go into details of that. Essentially, we trained the health workers, the primary health doctors for early detection of 3 common cancers or 4 common cancers, and trained about 700 health workers. About 80,000 public were screened. This project led to about 600 biopsies, and about 172 neoplasms were diagnosed. About 110 were cancers, and almost all of them were in stage 1. And what was important was that system was put in such a way that the turnaround time for biopsy was only about 6 days. Shows that even in a government system, we can optimize that if provided you put a system in place. Now, that is the physical mode. Currently, I work with an organization supported by Tata's called KURIAKOSE. We use digital technology to empower primary care doctors to perform cancer control. We are establishing multiple community cancer centers throughout the state. Kerala is a pilot state, already established about 12 centers in the central part of Kerala. We are establishing another 60 in the next 1 year. And what we are doing is using some digital platform to integrate primary care to the cancer care. Now, this is important because if you look at that 2 patients I mentioned, the reason why they did not get diagnosed or treated properly was not because of the lack of knowledge, in the sense if you ask them to do an MCQ exam, all of them would have passed that exam, but that knowledge did not turn into action. To turn the knowledge into action, particularly when it comes to cancer, you need to empower them. And we believe that a foolproof method would be a digital technology. We have established a central command center where using that knowledge architecture, we take it to patients and caregivers and so on, and then distribute the care knowledge in multiple. I will not go into bore you in details of that. This was in fact one of the patient diagnosed in that process. Patient was picked up in a screening or awareness camp. Then patient herself came to the health worker. Health worker, based on that their questions, ulcer lasting 3 weeks, need a biopsy. She did not have to think twice, sent to the local place, did a biopsy, and managed the patient. Definitely the outcome is better than the 2 patients I mentioned earlier. That particular patient was managed around Thodupuzha. This is a map of Ernakulam and Idukki. We picked a central Kerala as a pilot area because Idukki do not have a cancer facility. Ernakulam, by the way, has the largest number of cancer centers in the country. And this patient was picked up here. And this patient was managed as if the entire community is a cancer center, not just in one building. So as Sudhish mentioned, developing cancer care center without wards. So this patient had a CT scan done somewhere, surgery was done one place. Fortunately, patient did not have to go to radiotherapy, required sent to another place, but the radiotherapy is planned centrally and so on, so that we can standardize the care. Moving forward, multiple technology people can develop. This is one of the device we developed and currently just about to develop already prototype developed, implement in a community setting. This is I will not go and bore you in details. This is a probe attached to a mobile phone. This can take both white light as well as fluorescent image. Using machine learning, this image will tell us whether this lesion is suspicious or not, and then can triage the patient for a biopsy. And summary of that result: direct examination by the frontline health workers, accuracy was 70%. With the phone neural network, it's about 79%. If you send that image to the cloud and the cloud do the image analysis, we increased about 87%. Mind you, this is only about 5,000 patients. It's very close to what you and I can get. So with number, this can become fairly close to what a clinician can get. Rehabilitation is one area. Our specialty can play a role. Implant is widely used. Digital planning is done. So that particular patient was resected. Fibula was put for reconstruction, and implant bone denture was given. Then finally, I just covered 2 more slides. I know I'm running late. Now, what can we do as a society, as a group? Okay, it's important that we take ownership of cancer, and then work with the training and awareness among ourselves, as well as among the community, develop a network of biopsy, and then develop a oral management dysplasia network, and finally form a group where we can coordinate that care. If we do, by the way, we started a training program under the leadership of Deepu. Deepu is a oral pathologist based in Anu Dental College. He has about 200 dentists, oral pathologists in that network, or does the biopsy and then manage the patient. So that training program, already about 40 people, dentists have signed up for that. This kind of training program will help to improve the awareness and practice in the dental community, where the maxillofacial surgeons can take a lead in managing such patients. So this is my last slide. I just want to summarize that closing the care gap is feasible when it comes to, and we as a maxillofacial surgeon should take a lead. When it comes to training, there is no shortcut. It's a long road. When it comes to practice, definitely I mentioned that we should add value to the patient as well as to the doctor. And I just want to point out that the road ahead is rugged. It's a very tough specialty. We lose patients. It's a long procedures and so on, but it's very, very worthwhile at the end of it. Research, try to solve day-to-day clinical problem rather than trying to do day-to-day, to do me-too research. Finally, I request and recommend that we form a oral dysplasia network within our community. Thank you very much for your attention.
Thank you, Moni sir. That was really enlightening, as expected from you. Sir, we have few questions to be discussed. And the first question that I would like to ask is, we see a lot of young maxillofacial surgeon coming into the specialty for interview, and we get a lot of queries regarding training, and most of them without any background or any exposure to surgical oncology. So whether they have the idea, whether they have any idea about the reality as an oncosurgeon, the life of an oncologist. Can you comment something on the life and the challenges that an oncosurgeon faces in their life or a profession?
Yeah. Well, I am quite qualified to say that I've gone through multiple training programs in different places. I just want to point out it's a very hard specialty. Unless you have the endurance power, it's difficult to sustain. I remember when I was a fellow at Roswell, my wife used to tell that I can stand and sleep. We used to sleep for 1 or 2 hours if you're lucky, and sleep between cases and so on. It's a hard life, and that never stops. Even now, we have to pursue. It's a hard work. But it's one of the most rewarding specialty. I will, even if I'm starting my career all over again, I will go into the same field. The reason is that this is one specialty we can decide whether that person is alive or not. We can save people's lives. Not many aspect of what we do has that luxury. And mind you, we lose patients. But I give an example. Some of my happy or thankful families are the patients I lost. Okay, when I moved from Ernakulam to Bangalore, I gave my phone to my daughter, and she said she's getting so many calls from people, anniversaries and birthdays of people. They passed away. So those are the things. People became very close to us. So this is, in that way, it's one of the most rewarding specialty. Yeah, so I would encourage them, but it's a tough specialty, emotionally as well as physically.
That was a very strong statement, sir. If you get a chance to restart your career, you'll start with oncology. That was a very strong statement that shows the dedication. And so the next question, the question is, after maxillofacial training in India, can we do fellowship in the UK? That's a question.
No, unfortunately, you cannot. You can go for registrars, locum registrars job and so on. They have something called the fellowship, and fellowship is open only those with the CCST certificate. I may be wrong. I finished my training long time back. From what I understand, they should have the CCST certification. Whether they give exemptions, I do not know. But I believe you need to get that CCST.
Yes, sir. Thank you. And next question is, the question is it worth getting trained in head and neck surgery, being a maxillofacial surgeon?
So absolutely no question about that. We can add definitely value more than any other specialty, any other surgical field. Look at when it comes, because if you look at the entire head and neck area, the oral cavity, paranasal sinus is where surgery plays a significant role. Larynx chemoradiotherapy, oropharynx radiation chemotherapy. Oral cavity is where surgeons play a significant role. There's no other, the discipline has got better understanding about oral cavity than us. Okay, I give an example. Let's say that we can do a sagittal split without splitting a lip. We just go into the oral cavity, do a mandibulotomy and everything. So that because of our thoroughness of the knowledge about the bony anatomy and so on, all the others have to have a long way to pick up that, and our connection with the dentistry and so on. So maxillofacial has got a significant edge over our specialty, as you have seen that in Europe, UK, or if you look at most of the head and neck surgeons are maxillofacial based. Europe is same. North America, no, because otolaryngology made a big jump by getting into reconstructive surgery early, way back in 80s. Erkin and others led the microvascular era. So in North America, but their maxillofacial is coming back in that in oncology.
Yes, thank you. So the next question is on the career opportunities of a maxillofacial surgeon in head and neck surgery. That's the question.
Yeah, it is a major problem. That is, I believe that is one of the major problem we have. The reason is that we don't have a accredited training program. That's one thing. Second is that our trainees are not willing or daring themselves to go into the smaller cities to practice, establish. Okay. Dr. Nandini is one of my fellows from NH. Okay. She's from Bangalore. She went to Bellary, started a practice. Other day she sent me a image of a fibula she did and so on in a small place. And you should be bold enough to do that. And there's plenty of work there. Okay. But you have to compromise on your creature comfort. How people tend to stay in big cities. Unless we do that, we will not be able to, at least at the beginning. Later, once a specialty become established, definitely opportunity better. Look at cleft lip and palate. Our specialty is doing a tremendous job. Similarly, oncology also, we can do a tremendous contribution.
Yes. The next question is, do we need to have publications to be qualified for oncology fellowship training?
No, it's a surrogate of your interest in the field. Okay. So when we interview the people, not that if you have 10 publications doesn't mean that you are better qualified to become a fellow, but that shows that person is interested, willing to put in effort, and curious about the field. Okay, so that's a surrogate of your interest in the field, yes. And a good surrogate.
Yes. And one member would like to know the list of books that you should read for training in OMFS oncology. Of course, the first book will be your book, sir. That is the best book that we can read. Can you suggest some more books?
No, I strongly recommend not to read books, even though I've published books, not to read books. Because when we were in our training program, NH, everyone is supposed to present articles in our journal club. And we have a collection of articles. There are multiple review articles are there. If you go into any areas, the multiple review articles are there. So I recommend everyone to read review articles, but you have to read one book, any one book as a base. For example, when I was doing my head and neck fellowship, so I was reading the Shah's book as my, I just read cover to cover. That was just as a basis, but I didn't stop it. Of course, I went delve into each of the areas much more detail by reading the original works in that field. And if you look at it, this is such a small area. You know, how much you have to read. It's very, very small areas to go into in-depth knowledge. And knowledge is something if you don't have in that period. I always tell that if I do not know all the publication in my area, which has published in the recent past, I should not practice.
Yes, sir, that is a very good point that you made. And next question is, why is it not possible to have a dual residency program in India, say for 3 or 4 years, taking advantage of our undergraduation? Probably, I didn't get the question completely. Probably they're asking about bridge course or something. I don't know. Can you elaborate on that, sir?
Yeah, I think there was people have made the suggestion. There was a condensed MBBS kind of thing. There is no need for us to go through the entire medical curriculum. That I believe is, I went through that. Doesn't mean that the next generation needs to go through that. But there should be a condensed training program is required. But as I mentioned, to become a cancer doctor, you should have it's not just a surgical cutting alone. You should have the ability to manage the patient as a whole. And the way oncology is progressing, surgery will play a small role in the future. Definitely more targeted therapy, immunotherapy, and all that plays a role. And we should have a in-depth knowledge about taking care of the patient as a whole. And the condensed MBBS is the way to go for.
Yes. Next question is, as compared to other specialty in maxillofacial surgery, oncology has got more mortality. So it creates a big dilemma to choose with oncology. Any comments on that, sir?
I think that's wrong statement, is that right? If you look at ENT, for example, they have multiple options. General surgery, so many options are there. We do have various options are there. Oncology is one of the options, but the current, a lot of people are showing interest in oncology, but I do not think that the interest will last for too long. Once they start work and you know, see the reality of the specialty. Yeah.
Yes. And next question is, which is the preferred center in India to do fellowship in onco?
I am biased, is that right? I always say my center Narayana because I'll tell you what. One thing I really want to. I know there are some teachers also in the audience. See, one thing I always insist that surgery is a skill you can learn only by doing. You cannot learn by watching. Okay. And if a mentor cannot take a student through a procedure, he or she should not be a teacher. I'll give a good example. When I moved from moved from UK to US, took my fellowship. The first day I arrived in Buffalo, sometime in I think Saturday or something. Monday was my first day. I scrubbed a surgery patient. I don't know. I can't remember what exactly was it. I went to the assistant side, so he asked, my mentor asked the question, now you're not operating. So he made me to go to the surgeon side and operate. So that kind of mentors are required if you were to produce good surgeons. So all of us as a mentor should have as a responsibility to train. Otherwise, they should not take students.
Yes, that was a very valid point. And next question is there any legal considerations doing a microvascular reconstruction surgery as a maxillofacial surgeon?
Absolutely no. Absolutely, 100% not.
Yes. And these are the questions that came regarding the training aspect. There are a few questions on the disease aspect as well. So I'll mention those. First thing is there any Government of India program for early detection of oral cancer?
There is a National Health Mission. There is a program, not just oral cavity. There are about 3 or 4 cancers put together. It's by the Hewlett-Packard or some group working on that. But in Kerala, it has not. But there are Karnataka and a few other states. It's been adopted.
Yes. Another question is there any structured algorithm for following up a patient with premalignant lesion?
Yeah, there is a, guidelines, not established guideline, not what you call for that. It's not like a NCCN guideline. We don't have one. Our group has published one in Indian Journal of Cancer from a consensus guideline. All few of the experts sat together, and I recommend you to read that. First of all is Praveen Bayrur published on that. Essentially, you stratify the patient into high risk and low risk based on the clinical features and history and so on. Then after biopsy, you stratified again to high risk and low risk. All the patients, if there are risk habits, stop the risk habits, and then the structured way of follow-up. One important point is never lose follow-up. Even though it's boring to just call the patient and say hello for 2 minutes, you just have to keep the patient on your follow-up.
Yes, thank you. And there are like how to encourage a patient or motivate a patient to take treatment for oral cancer.
Yeah, that comes, motivation comes from the confidence you have with the success of the treatment. Okay. And you have to, most of the time, some of the patients say deny treatment. You have to find out what's the reason behind that. You have to come to the level of the patient, communicate well. You have to tell the patient what are the consequences of going through a treatment and not going to treatment. Okay, not to scare the patient. And also, you have to give the patient enough time. And if the patient denies treatment, there must be a definite reason behind that. That also is your responsibility to find that out. And of course, finally, the patient make a call. There are a number of my patients say that I don't want to go to treatment, but I will never stop following up the patient. I completely always, they are with me, whether they go to radiation, no treatment, Ayurveda, doesn't matter. I said, I'll be with you, whatever they choose.
Okay, sir. And is there how to next question is regarding management of dysplasia. How to manage oral dysplasia?
Yeah, so that's a topic on its own. Hopefully, we'll get. That's one of my favorite topic. We have done a lot of work in that area, but I think it's a challenging term. One thing is that dysplasia is not a good marker surrogate for malignant transformation. Even mild dysplasia, non-dysplasia will turn into cancer. So whether there's a dysplasia or not, never stop following up the patient.
Yes. Do you recommend primary reconstruction in highly recurrent lesions?
Always. If I operate, always reconstruct.
Yes.
If I don't choose to operate, that's a different thing. If I operate, operation comes with both ablation and reconstruction together, one package.
Yes. What is the scope of mRNA vaccine in oral cancer treatment?
Yeah, that is not just oral cavity. It's going to come multi-pronged vaccination type of approach will come, but we should not call it as a vaccine. Vaccine means prevention, is that right? This is a therapeutic vaccine. Not use mRNA to target different molecules will come. Using some kind of CRISPR type of technology. But vaccine per se, not as a preventive side, no.
Yes. Sir, do you recommend surgery for T4 lesions?
Well, you're asking me. I'm the biggest proponent of that.
Yes.
I will always say that not T4, T4B. We have shown that that patient I showed earlier. That I showed one of my failures, but our group has shown that 67 something percent survival if you resect and appropriately reconstruct, followed by radiation, buccal mucosal cancer. So T4, is one topic you guys can take it up for research. That T4, who made that definition T4? T4 was done by people sitting in a country where tongue is a common cancer. They never used to see, they don't see that often the buccal mucosal cancer. So where masticatory space involvement, skin involvement is very common, and you labeling that a T4 to me is a misnomer. That should be changed. But finding data to support is our responsibility. C4 definitely, definitely.
And there are evidences. DIAO paper says that low ITF-T4A lesions behaves similar to low ITF-T4B lesions. The results are comparable to T4A lesions. So I think And so maxillofacial surgeons are usually overlooked over the medical counterparts or even getting placed in an onco center. Any solution for it, sir?
I explained that before, is that right? Because we don't have the approved, nationally approved training program. But even with MCH in head and neck started only recently, but still this is a challenge. But if you look at how cleft lip and palate, our specialty has established, oncology can be established, provided we go out to the periphery and practice. Don't sit in a big city and try to establish practice.
Yes. So being a maxillofacial surgeon, are we allowed to do an orbital acceleration as a part of surgery?
Why not? I don't see any. It's not the limit. So, but I have seen that people talking about there are a lot of things we can do in our field. Is that right? Why do you want to get into one area which we are not comfortable? Say maxillary tumor going to the eye, need an orbital acceleration. That is not a major issue. But let's say orbital tumor per se, that I think as a maxillofacial surgeon, whether you want to get in, depending on the training program, your training background.
Yes. Is there any age limit or age limit for oncology training?
Age is, no, I don't think, but you have to start young, because there are the time when you'll be more confident to take decisions and so on. So age is not a bar. My mentor Bekamchian was in the war. He went to medical school when he was in the mid-30s. Okay, he's one of the father of plastic surgery. So age, I don't think it's not criteria.
Okay. So I think most of the questions. I'll take one last question, sir. How do you get into your fellowship program?
Unfortunately, I'm not. My Vijay is the person now doing the fellowship programs. I go there to help him out. But I strongly, it's one of the better training programs, but tough one to go through. There are some.
So that was very wonderful session that you gave, sir. I think we are done with the questions almost. And just I will take 2 minutes. I couldn't share my screen. I want to show that I put some effort. So I am taking a few minutes to share the presentation that I made for you, sir. Can you see this slide?
Yes, Sudesh.
Yes.
Yeah, this was the opening slide to introduce MONI, sir. He's the director of, for the late joiners, I will repeat once again, just 2 minutes. He's the medical director CEO of Kerala Operations, Kakinos Health, and vice chairman of Department of Health, Head and Neck Plastic and Reconstructive Surgery. And he did his BDS from Manipal in 1983. And subsequently, he pursued his medical training in 1992 from Bristol, UK. And he completed his residency in general surgery as well as maxillary surgery from UK, and completed fellowship in head and neck from Roswell Park Cancer Institute. And he is an American board certified oral and maxillary surgeon as well. And we can be very proud that he started his professional career as a dentist in India, and then he joined the New York University as a director of translational research program after his medical and surgical training. And he was instrumental in developing head and neck center in Amrita Institute of Medical Science, as well as Narayana Hrudayalaya. And he was the founder director of Cochin Cancer Center and Research, Cochin Cancer Center, which is in its initial stages of budding. And he's currently the medical director of Kakinos, as well as vice chairman in Roswell Park. And he has around 321 publications. I don't know whether it is recently updated. Anyway, more than 300 with 4,500 citations altogether. That is a very huge number for and this is one of his textbook. It's a 4-volume textbooks in oral oncology. It's a very comprehensive textbook. The person who asked about the textbook, this is one textbook that you should read to get a comprehensive knowledge of oral cancer. And he's an editor-in-chief of the journal Oral Cancer by Springer Nature Group. And apart from all his achievements, he failed in his gynecology exam during his training in Bristol University. But it was a reason to, it was actually, it could have lost, he would have lost 1 year during, because of this, but he was so determined that he don't want to lose that year. And he cleared all the subjects of medical course and the exams in the University of London in one go. I don't know how he did that, but he did that and he saved that single year. It was not just saving that single year. It was a determination to save that year. And that determination was probably the boost to bring him to this much height. And Moni sir is on a mission to create cancer centers without wall. And we are all happy to associate with Moni sir to fill those gaps in cancer care. Thank you.
Thank you, Sudesh.
So over to Varun.
Thank you, Dr. Sudesh, for moderating the wonderful session. Agreed, sir.
Edward, sir. Now I request our Dr. Vikas sir is there. Dr. Vikas Super sir is there. He is the president-elect of AMSA India. I'd like to invite him to share his views on the webinar and also to share his words on how the Onco Fellowship in India can be improved. Over to you, sir.
Thank you, Dr. Edward. Thank you for inviting me. Thank you, Dr. Pratap, Dr. Sudesh, who moderated the session. And thank you, Dr. Moni KURIAKOSE, for a wonderful presentation. It's always a great pleasure to be listening to you and your vision. You are always 10 steps ahead of the rest. And the clarity in your thought is amazing. And I think you're the best person to be there for celebration of World Cancer Day. And kudos to the Kerala chapter for organizing such an event. And now, rather than being just surgeons, you have been looking much ahead, how to integrate every aspect of management for a patient, which is exemplary. Now, you did raise some points that there is a challenge because the fellowships are not recognized, and it becomes a problem for people who have done fellowships and subsequently who seek jobs and who look for placements. It does become a problem. I fully agree with you. And although we have tried quite a number of times in the council, I have faced numerous issues, and I'm sure you know how the government functions. There is always going to be some issues. let's see what the best we can do. Maybe if not dental council, the new body which is supposed to come in, which will probably can take a better look into it. Cancer, I can always say it's a challenge, and the hard work and the perseverance of a surgeon is what is needed. Yes, I fully agree with you. At a younger age, if a surgeon gets into it, then he can mold himself. At a later, of course, age cannot be a deterrent, but yes, older age and maybe a little bit of a difficulty into doing certain kind of procedures and bringing up skills. But then if you pick it up early, I am sure it's going to be really good. And it is for the maxillofacial surgeons, it is a field, although you may find it very hard and you may find it very difficult, to work in it. But yes, it is the field, it'll be the most gratifying field. The rest, most what we do is cosmetics and other procedures which are quick money. But beauty was not going to be there forever, but lives are going to be there, which are lives which you're going to change with the surgery is going to make a lot of difference. And I think that's a few things what I would like to say. Dr. Moni sir has already elaborated on the most of it. I thank you for having me here, and over to Dr. Edwards.
Thank you very much. Thank you, sir, for your valuable words on this. I hope that with your presence, this has made a fruitful one, with Dr. Moni delivering a wonderful lecture and giving us a thorough knowledge for the young budding surgeons, as well as for those who are going to choose this oral oncology as their career program. Over to Dr. Aglesh for his session. I think we'll have the vote of thanks by Dr. Aglesh. I hope each and everyone has benefited out of this CME program. Dr. Aglesh.
Yes, thank you, sir. At the outset, I would like to thank our faculty for the day, Dr. MONI KURIAKOSE. Thank you, sir. And thank you for delivering a wonderful lecture, and also for patiently answering all the questions which are put forward to you and giving your insights into many things. I'm sure that many people will be inspired by your talk today and will be willing to take up oncosurgery as their specialty after post-MDS. I hope more and more people will join. Thank you, Vikas Dupa sir, for sharing your views on the program and also for giving your views. I am sure that you will be able to much more in the Dental Council of India or the National Dental Commission as it is formed. And you will be able to, maybe in the future, all of us together can work together, and then recognition for some of the fellowships, at least in the through the National Dental Commission or through some government agency, so that we are treated at par with other surgical oncology specialties. And I would like to especially thank Dr. Sudesh and Dr. Varun for coordinating the session, taking care of all the technicalities. And thank you for all the participants for being very active, for actively participating and also asking questions and getting your doubts clear, which was useful for all of us, not just some of us, which was useful for all. I am sure that everyone has got one or other take-home message from the talk and the discussion after that. Thank you all. Hoping to meet you all in future again for such sessions.
Aglesh also,
thank you.
Aglesh also thanked the HODs for having their PGs to.
Yes, I would like to thank the head of the departments and all the postgraduates, head of the departments who insisted that the postgraduates attend the program.
And the AMSA office bearers who have been the part of the program today. Thank you.
Yes, sir. And I would also like to thank the AMSA office bearers, both state and national office bearers who are here. We had some trouble at the beginning, but I think later on it was sorted out. Hopefully we'll meet you all in the near future for another program. Thank you all once again.
Thank you. Thank you. Thank you.